Okay, we have a lot of interesting stuff to discuss today, especially notably the legislative materials a little later on. But first, let's welcome everybody, and let's start with the numbers, as they say. We actually have some really good news from the medical examiner, the Palm Beach County Medical Examiner. We have, again, this is preliminary. The count is not complete, but we're getting closer and closer. I suspect by March or April, we should have the complete numbers. But right now, as of, this should be, this should be actually as of February, not 12/31. But as of 12/31, meaning the entire year to 2022. Okay. Total drug overdoses were 555. Now, understanding there are 21 cases that have not, the toxicology reports have not been submitted to the medical examiner. They're suspected overdoses, but we haven't confirmed it, and we don't know what the nature of the overdose is. So keep that in mind as we run through these numbers. The total opioid overdose deaths stand at 410. 74% of the total OD cases, which is less. The 74%, last year it was 79% of the total overdoses. I think I have a potential reason for that, and that's Xyloxine, which is non-opioid, but it's killing people. There were 41 deaths in 2022 so far from Xyloxine, which is called Tranq on the street. You have some articles about that in your handouts. But 41 deaths, OD deaths, so that could account for the decrease in the opioid overall numbers, and even though there's an increase in, well, not an increase, but on the total overdose cases, drug overdose cases. An interesting statistic so far is fentanyl and fentanyl analogs present. 97% of opioid overdose deaths, fentanyl or fentanyl analog is present, which is up from about 91% last year, 91%. So it's in everything. It's in everything. The projected opioid overdose death total is 426, and this is how we arrived at that number. We took the entire remaining cases, 21, and we took 74% of those, which is 16. We added it to the 410, and we get 426. The good news is we haven't seen numbers like that since 2018, when we're at our lowest stage. I mean, it's appalling that the death rate is still so high numbers-wise, but with fentanyl, that's really driving the numbers right now. We would see a stark drop, I believe, in Palm Beach County. It should be noted in 2021, there was an increase of 5% of opioid overdose deaths in the state, even though there was a 13% decrease in the overdose deaths in Palm Beach County for 2021. So we had 519, according to the raw data, which our analysts reviewed, the raw data, 1 death, 1 opioid. And we were at 519 for 2021. 426 is our projected number for 2022, which is an 18% drop. I mean, that's in a sea of bad news, that's good news. We're looking at another 18% drop, 2022 over 2021. The new fentanyl analogs that we were talking about earlier in the year, the NPE, which I can't pronounce, but it's a fentanyl analog that's 20 times more potent than fentanyl. In 2021, there were 0 overdose deaths attributed to NPE. So far, with 21 cases left to review, there are 19. So that's a driver. That's in the drug supply, and it's spiking. Fluorofentanyl, similar potency to fentanyl, another fentanyl analog. In 2021, there were 6 overdose deaths caused by fluorofentanyl, and you can see the numbers in so far in 2022, 98, almost 100 of the 426 deaths had fluorofentanyl as a cause or presence. And I suspect probably the cause. Okay, those are the numbers from our medical examiner. We thank them very much for always keeping us updated. We also have the complete year numbers from the Palm Beach County Fire Rescue, 1/1/2022 to 12/31/2022. In your handouts, you have the numbers, the annual numbers for the last 6 years, from 17 to 22. I'll just leave you with one statistic, because you can see when you look at your handouts, and everybody should have them. If you don't, by the way, if you're on this this Zoom meeting and you don't have the attachments, you can request. You don't have to be a member, or a participant in the actual state attorney addiction recovery task force to get these materials. M Senator, Mary Ann Senator, msenator at sa15.org. And she'll put you on the list. We have probably 150, maybe more, on the list that actually receive these a notice of the meeting, and also the attachments. But anyway, I don't want to go through these numbers in depth, but just to say that between 2017 and 2022, Palm Beach County has experienced a 46% drop in opioid overdose calls to fire rescue. Now, Palm Beach County Fire Rescue is roughly 50% of the fire rescue departments in Palm Beach County. We have a number of municipalities, but we believe that probably the similar numbers across the other 50%. But 50% of the overdose calls in Palm Beach County taken care of by fire rescue. There's been a 46% drop. A significant fiscal impact. I mean, this, it's not only the good work of this task force and the law enforcement side, but all the people that are involved, Ariana Ciancio and Delray Beach, the availability of Narcan. There are many reasons. The addiction stabilization unit, many reasons why these numbers have gone down. But talk about a fiscal impact. It's probably a savings to Palm Beach County of over $7 million to about 46% reduction. Because back in 2017, we estimated $7 million was being spent just on calls for opioid overdose. Anyhow, anyone want to chime in on? I did mention xyloxine. You have 2 articles that are in the handouts. It is of concern. It's not an opioid, and sometimes it's not identified, but it is up and coming, and it's going to be a significant driver in our state in terms of street drugs and overdose deaths. Anybody want to comment on the stats I just gave you? Okay, good. Let's move on to okay, Ariana, you want to give an update on Delray Beach? I'll let you do the stat for Delray Beach, which everybody has gotten in their handouts.
Okay, so hi everyone, it's been a while. I'm looking at my computer while I'm on the phone with all of you, so I'm sorry that I'm not looking at the screen. So our stats obviously have fluctuated over the last 5 years. That was my final number for 2022. There was 219 overdoses and 30 of them, so resulting in 249. I'm still holding on. We haven't heard back about 4 medical examiner reports yet. We have 4 deaths that are not, we don't know what they had died from yet. In our overdose numbers, just in the deaths, some of them are alcohol, because technically when they do come through the city as an overdose, everyone's an overdose until we find out what it is. And we've been keeping the alcohols in there because we don't want to really pull them out, and unless it's a medical and we know it has nothing to do with a substance, we pull it out, but for the most part, the alcohols will stay in there. So of the 30 in 2022 of the deaths, I can give you the number of, let's see. I can tell you exactly what they, so 21 are confirmed fentanyl. One of them is a prescription pill. 8 of them are unknown or other. So then that leaves the other 4 we're still waiting on. So obviously it's clear that our numbers are down from the last 5 years. You know, Narcan has been huge out on the streets. It's been great. I don't know what else to say other than, yeah, we're all working our butt off and trying to make change. And I think we're doing it. But it doesn't mean we're out of the woods. There's a lot, like in Delray right now, everyone I talk to that's out there using, what are you using? I'm using Molly and meth. So that's all on the streets right now. We've had a couple overdoses recently that overdose deaths this month, that the only thing we found there is powder cocaine. Hasn't been tested yet, so we're assuming all 3 of them were fentanyl. But it's nothing out of the ordinary. We're used to this now, which is horrible. But we are.
Ariana,
Yes.
are you still seeing fentanyl polluting other drugs?
Yeah, the
in terms
cocaine.
of people overdosing that
Yes.
may not have been looking for opioid, but overdosing on cocaine or meth or
Yes.
some other drug.
So cocaine is a definite. Last month too, we had 2 guys that were just hanging out at a bar in Delray, went down to Boynton, decided to go buy some cocaine, came back and both overdosed. They had no idea there was an opiate in their drugs. And again, there are 3 deaths that we had this month. The medical examiner report's not back yet, but opiates were not found on scene. It just looked like powder cocaine. The other thing I want to share as far as Narcan for 2022. The police department used Narcan 68 times on the overdoses. And we got some good news recently that one of the local police departments that was not using Narcan had reached out to us over the last month and was inquiring on how they could start using Narcan as well. So, they're just now that PBSO did it, I think the other police departments are going to start trickling in.
Yeah. That's actually good news. The greater availability, but drugs like Trank, this Xylaxine, obviously Narcan does not work on Xylaxine, and which is troublesome. Is that somebody trying to speak? Or? Oh, Jeff Lynn, you had a question?
Yeah, Al, from a criminal justice prosecutorial standpoint, what does the county do with people like Ariana just described, who say we're in Delray, drive down to Boynton to find some cocaine and then get it? Are those people arrested?
I can tell you from my office's perspective, and in regard to the Sober Homes Task Force, the end user, the person who's addicted to drugs, is not a target in any of our investigations. As a matter of fact, in order for us to do an investigation, Jeff, you know that we need to obtain a Title 41 clearance from a judge, and the statute actually says if you're going to investigate a treatment facility, we cannot, nor would we, prosecute possession of drugs or low-level drug offenses. Obviously, if it's a murder or a serious crime, that's an exemption. But we're not. I never have been since Dave Ehrenberg has been at the helm, and even back to the days of Barry Krischer, interested in users of drugs other than to get them treatment or into treatment, to get them on the path to recovery. And with regard to street drugs and street crimes, sellers of fentanyl are targets. There are mitigations in some cases, but if you're peddling death, beware. It has nothing to do with the task force, but it has to do with organized crime, and it has to do with dealing death. The laws have been strengthened, And you can bet that we will, those persons would be targeted, but not the users. Never
Yeah, but
the,
I'm thinking more about people, not people that have an addiction or substance use disorder, people that are seeking cocaine or other what they would deem recreational drugs, who would be, on the demand side of things coming to our county, seeking drugs, and then you have a willing buyer, the dealer of death.
and
And while I certainly agree going after the supply, the demand side, when it's not from a substance use disorder, but as a street drug person, I would like to think that those people are not treated with kid gloves either, unless they're facilitating the arrest of the person who is selling the drugs.
well, I hate to use a broad brush, Jeff, because every case is unique and every individual defendant is treated that way. It's not a cookie cutter system in our office, but is a recreational user of drugs absolved of any liability? No. Nor is somebody who has a substance use disorder necessarily. That's why we have drug court. That's why we have diversion programs. That's why we ultimately will drop cases when it's appropriate. And in no way do we target or for incarceration people who are recreationally using drugs, but we will prosecute because we have to. It's our ethical duty to do so. But prosecution takes many different forms, and diversion is the preferred prosecution of somebody who's just a casual user or even an addicted user of drugs. So I guess that's how I would answer that, Jeff.
Thank you.
Anyone else?
The question in chat, I think it pertains to Ariana,
Okay, there's a question in chat for Ariana.
right here. Deborah she's asked.
Oh, I don't believe that Delray and Ariana, you can correct me if I'm wrong. We're not data collectors as such. I'm crunching the numbers. I'm sure that the medical examiner probably has that information on overdose deaths, which is, racial or gender data. Ariana, I don't know if you keep that or not in Delray. It's really not our purpose here, because we look at the overdose death and overdose morbidity issue writ large across the population. And we know that that many of, especially the out-of-state people who come in for treatment to Florida, are young demographic, 18 to 35, historically male, historically Caucasian. There are females, obviously, there's a percentage, but that's not really what we do here, aggregate that kind of data. Ariana, correct me if I'm wrong.
No, I agree with you, Al. We don't get that down. We're just basically looking what they overdosed from, if Narcan was used, who provided the Narcan, just to basically calculate those numbers.
Yeah. We're triaging here, trying to lower the death rate and increase the ability of people to get good, honest treatment and long-term rather than acute, since this is a brain disease, and hopefully make a difference in that way. You'll hear about the ASU as well. Okay, next
Can
up.
I clarify my question before you go on? And I'm sorry to belabor the point, but one, I was not asking the question really for Ariana, but that's fine. But secondly, this is Dr. Deborah Robinson. So what I've read and what I've heard anecdotally is that there's an increase in the overdose deaths in the Black community. And so, I mean, and I've seen that like in national articles. I don't know if that's true here, but it seems to me, and maybe it's not this committee's job, but there's disparities in all of these systems, right? And so I just want to make sure that we look at data in such a way so that we can target the solution, because it's not going to be one size fits all. But thank you for listening. Thank you for having me.
Deborah, I'm Dr. Robinson. You can access this data. I'm pretty sure if you look at the Florida Department of Law Enforcement medical examiners OD death report, opioid overdose death report for 2021. I believe they have it broken up by gender, race, demographic. And if not, our medical examiner, you could do a public records request to get their data from 2021 and look at it. I'm sure it's there. What we're trying to do here is a little bit different, but I appreciate the question, and let's move to. We already talked about xylexine. Is Whitney on yet? Susan?
No, I really think she's ill, so.
Okay.
I heard from her, so.
All right. I believe her phone
Probably
was
if-
off this morning when I tried to call.
Yeah.
What I'll say is based on last month's, I am so proud of FAR and what FAR has achieved in Florida, Florida Association of Recovery Residences. We had in our last meeting 2 months ago, over 7,000 beds that are certified in the state of Florida. I don't think you could put the next 4 states together and add them up and reach 7,000. We're the model for the country, and I'm going out there pounding the pavement, not only in Tallahassee to help FAR, but also been doing various meetings and in DC to try to get the word out nationwide that if you don't attack housing with these opioid dollars and you don't look at housing, you're losing a big percentage of bang for the buck. Let's put it that way, because sober, safe housing is one of the keys to this long-term brain disease, opioid use disorder. So very proud of FAR, what it's been able to achieve. We'll be talking about some issues in the legislation. And let's move on to Lori Holtzclaw Hunt with Oxford House. Very proud of Oxford House as well. 5 years ago, we didn't have a single Oxford House in the state of Florida. And now, how many do we have, Lori?
116.
Wow. Great.
Can you stop sharing your screen, Al? Am I going to be able to share my screen?
You will. We've got limited resources here. But go ahead and share.
That's okay. Hi, everybody. I'm Lori Holtzclaw Hunt with Oxford House Inc. And I'm going to give you our little report for Oxford House in Florida. So this will be for January.
Isn't she on our?
She is, she's up.
We have 116 houses with 1,034 beds, 70 men's houses, 625 men's beds, 1 men and children, and 8 beds there. 25 women's houses, 217 women's beds, and 20 women and children's houses with 184 beds there. These are the cities we currently have Oxford houses in, and that actually kind of continues on to the next page. So we're opening houses in various different cities across the state. It's going very well. These are the cities that we look to open houses in the near future. And then we've had 3 non-fatal overdoses revived with Narcan and 1 fatal in Gainesville. We have some upcoming events. Our 2nd annual Oxford House Florida State Convention, May 5th through the 7th in Orlando. Our 2023 World Convention in August at the Gaylord National Harbor in Maryland. And then our 2024 World Convention is going to be in the fall of 2024 at the Rosin Shingle Creek in Orlando. So we'll be sending out invitations to a lot of different people. Definitely probably you, Al, and maybe Dave, and several other people from the Sober Home Task Force. We had a big leadership summit last month. We provided in-depth training on our housing services, and over 100 Oxford House members from across the state attended this. Due to the flooding from Hurricane Ian, We had to close a couple of houses, but one of those is reopened already, and the other one will be opening this month. And then all chapters in the state continue to do Narcan administration training. We have, the outreach workers train pretty much on a monthly basis on how to administer Narcan, and we make sure that the houses have Narcan throughout the state. And some of the areas are designated Narcan providers in the iSafe Florida database. And then again, the convention in May, we're going to be focusing on training for the Oxford House model, recovery, and building the community. So here are our contact information, websites, mine and Michael's. Michael is our regional manager for Florida, our new regional manager recently over the last year. And if you have any questions, I am here to answer anything anybody may need.
Al, can I just jump in for a second?
Sure, John, go ahead. John
Yeah,
Hewlett.
thanks.
Palm County.
No, and I really appreciate your comment around housing. But let's be clear, though, the predictor for long-term recovery outcome is housing stability. So,
Right.
in terms of getting to a stable housing environment, I'm learning more and more, particularly from our federal research project, the COSAP project, that we need to be looking at sober homes as transitional living, which is in essence what they are, but always keeping our eye on the prize of making sure that our population is in, more stable housing environments, either supportive and or affordable. So, we've crafted a system over 40 years. It's kind of like get treated, go to sober home, and it's the end game. In essence, it really isn't. So, and would love to tease that out a little bit further moving on.
Yeah, John, you make an excellent point. And the concept behind sober homes as I see it and my office sees it is more in line with, okay, there are short-term housing availabilities. Certified housing, of course, is much more stable and much more likely not to be a warehouse or counterproductive or at best and a flop house at worst. But recovery residences don't mean, and Oxford House bears this out, it doesn't mean it's a short-term stay. It doesn't mean it's a transient stay necessarily. The concept of FAR certified recovery residences in Oxford houses, and I agree with you completely. We have to look at, this is a brain disease. If somebody needs to be in that nurturing, supportive environment for 2 years, for 5 years, before transitioning into the community and not have those services and support, so be it. I don't think that Susan, correct me if I'm wrong, but I don't think there's any limitation on the stay at a certified recovery residence through FAR. So we're both on the same page, and there are different levels of housing as well. But yes, I agree. But the recovery residences, as they are defined in statute, need to be safe and need to be productive.
Which is part of FAR's role, right, is to oversee the recovery residents and look at specific complaints about specific events at facilities for recovery residences, because I most assuredly can tell you that there's still a lot of, and it may not rise to criminal conduct, but there's a whole lot of negligence going out there. I speak that language, but like they're not following the rules, and it's to the detriment of their clients. So FAR needs to remain, supported and strong, so it sends the message, and the more that people end up in a FAR certified house, the more they will have that kind of stability. And if there's problems anybody knows of, you should let Whitney or I know.
Or call the hotline here at the state.
Or call the hotline, right? Whatever, but reach out, because we look at all of them throughout the state.
We got to get.
So I'm just, putting a plug in that, the credentialing, the credentialing makes it different and they get monitored. So there's a lot of stuff that goes on at FAR that isn't necessarily reportable here, but are problematic.
Yeah, and in that vein, how I really would hope that we could look again. I mean, part of the deficit here, and not to FAR's fault at all, is this lack of regulatory teeth.
Correct.
So how that gets resolved in this kind of quasi-governmental role is difficult, but this is not new information to us. And I can tell you,
Right.
trying to engage private sober home operators in a government pay system, via our what we learned through our federal grant program is virtually impossible. So it's really forced me to look at other transitional living opportunities, with supportive vouchers and the like. But
Right,
know,
John,
absent
you and
that-
I are going to need to talk about this. I don't want to belabor the point because we're not going to, there's not going to be any, we need data. We need to look at the problems that you're having, John. I'm unaware, it sounds anecdotal that, going up to a particular recovery residence operator or owner. But this is something we need to resolve. But I'm only bringing these things up, okay, in the context of the best we got. Okay, is it perfect? I got to tell you, the oversight for the amount of money that FAR has in their budget, the oversight is incredible. And same thing with Oxford House. I mean, look at the overdose rates at these houses. You're not talking about a couple of houses here. It's phenomenal. I mean, it's a tragedy that anyone will die of an overdose, and it's unfortunate that anybody overdoses, but that comes with the territory in terms of substance use disorder, especially opioid use disorder. But I got to tell you, Virginia, the governor in Virginia gave VAR, which is a FAR, Virginia Association of Recovery Residences, $10 million. Now it's a one-time appropriation, but my God, they don't have a fraction. Not to say that they shouldn't get that. Okay, if they have 1,000 beds, I'd be surprised if they have more than 1,000 beds. We have 7,000 certified beds in the state of Florida, and FAR unfortunately is on a shoestring, having to support themselves through their application fees, which is counterproductive, again, to begin with, because it's not like sober homes are private equity funds or a high profit margin in any stretch of the imagination if they're done legally and right. So anyway, these are things to talk about. I just want to pat on the back, Lori and Whitney, Susan, I know you're on the board. The job that FAR is doing, the job that Oxford House is doing to offer stable, supportive recovery housing for individuals who are in recovery and post-recovery. So, let's end with that, but I'm going to segue because now we have an issue with certified recovery residence administrators, which by law in Florida, every recovery residence that's certified needs to have the administrator. And I had some input about the dearth in the area of the number of certified recovery residence administrators. And I wanted Neil McGarry, who is the executive director of the Florida Certification Board, who certifies these CRRAs, to give us a little update on where we stand with the workforce. Hi, Neil. How's that for a segue?
That's pretty good. Hopefully I'll rise to the occasion. I wanted to say too that actually, as I told Al earlier, I'm on another call at 2:00 today, but it's for workforce within the substance abuse field, because we're seeing it, providers are having a hard time, whether it's COVID, whether it's workforce trying to get people back to work. The entire workforce within the addiction industry is struggling. And I'm sure Uta could could talk about it as well with her members. It's a big struggle. So we're trying to see how we can streamline the certification process and get people into the system who would like to go to work within the system. One of the things that we're looking, and I'll have to follow up with Whitney, is we're seeing, you know, for the amount of beds, 7,000 beds, we have, you know, basically 595 certified recovery residence administrators. And but what you see is a big increase first when the law passed, and then roughly year by year, it ticks down a little bit slower as for the individuals who are applying for certification. So as an example, last year in 2022, we had 39 new certified recovery resident administrators, and that's it. That's an extremely low number for us to process. And then what I did is also, I think Al was asking if we could pull apart where they're employed. It's kind of hard to say because they bounce around. We can tell you who they were employed with when they originally applied for certification, but we don't necessarily track current employment. But I can tell you how we broke it out based on the areas in the state. So as you can imagine, the Palm Beach County has 145 recovery resident administrators. That's the largest. Broward County has 91. And then it substantially drops off from there. As an example, Miami-Dade has 9. And I think it may have a lot to do with some of the other things that are, you know, Al, I think you'll talk about later in the legislation and how you're trying to streamline it. You're trying to get the fees implemented where people, if they are fined, they'll actually have to pay the fine. And I think the teeth in the law itself hopefully will pass. And so there'll be a little bit more rigor to it, so that if I think within the community, this is, you know, the substance abuse, sober home industry, if you're not one of the top players, sometimes there's a little bit, let's say, fraudulent behavior within the community of sober homes. And I think really they know that not necessarily do they need to participate in the law and get referrals and be certified by FAR in order to, you know, to satisfy the requirement of a recovery sober home administrator, basically because we just don't have the numbers. And originally I knew it wasn't going to be a big operator for the Florida Certification Board because of how the process looked. As an example, we do child welfare. We have 13,000 child welfare individuals certified. We have in the alcohol and drug industry, we have about 11,000 certified throughout the alcohol and drug and behavioral health and peers. So I knew that the recovery resident administrator would be a smaller number. But I guess from what we saw as the original 2016, you know, we had the initial push 2017, and then thereafter every year, it's kind of just fallen off a little bit, if you will, a lot of it. And I'm hopeful that as some of the loopholes in the law get changed, that we'll have the opportunity to credential more individuals. And as you know, the sober homes become certified in different parts of the state, we'll see an increase in the sober home administrators. That should just balance out as you need them. But I know we also expand last session, or maybe it was the session before, how many beds that the sober home administrators can be responsible for. And I think that may have had something to do with the decrease as well. But those are the numbers.
Okay. Thank you, Neil. We seem to have a workforce problem. We're gonna need to work on this,
Mhm.
because you can't blame a facility, and well, I shouldn't call it a facility. You can't blame a recovery residence that wants to certify but cannot find a CRRA. You know, perhaps we can work around if a CRRA leaves, that it's not 30 days, which the original statute says from 2018. But maybe we need a little more of a grace period to find somebody and make sure they get trained. I talked to Whitney about this, and FAR is not opposed to that because we have to face the realities of the workforce that we have, not the
Right.
workforce that we would like to have. You know, I'm up for any ideas that people have, just, you know, communicate them to me, as to how we can get through this I call it a crisis because
Mhm.
I don't think this is the driving force with those scofflaws who are trying to operate under the radar. I don't think this is the reason they're doing that.
Mhm.
But it probably contributes to it if they they already have an added expense by having to have a certified recovery residence administrator. We can look at the statute last year. I thought it really opened up the ability of a CRRA to have more houses, but not more residents. In other words,
Okay.
what we did was we changed the rule that said you can only have three locations. But of course, if you have 3 apartment buildings, you could have 300 people, 300 residents, and that was too many for one CRRA. However, 3 houses with 8 people in each house, that's not enough. I mean, a workforce in this situation. So we're not limiting the number of houses anymore. We're limiting the number of residents to, I think, 50 and then 100 with approval from FAR. And FAR has not been withholding that approval, as far as I know. So these are
Just-
things to work on. It's not in this year's legislation, but clearly that may be something we need to look at in terms of the amount of time between CRRAs, and perhaps we can, I don't know what else we can do.
We don't, and Al too, I don't mean to cut you up, I apologize. One of the things we can also look at it and tweak it within the certification standards. So those are things that we don't necessarily need to change in statute. But I think you're exactly right. Some additional focus on this area is obviously needs to be looked at. And just as an example, one of the things that we do with other workforce issue areas and other certifications is we have a provisional certification. So after the individual would get the education necessary, they would take a test, they would pass that test, and then they would come provisionally certified. And once they're provisionally certified, they can work. And then at that point, they're then gathering, if you will, the work experience necessary to become totally certified or completely certified within a certain time period, usually within a year. So that would enable, I think, a certified recovery residence administrator to become employable at a faster pace.
Well, that's a great idea.
So-
Okay, well, good for discussion. Anybody have any questions? We need to move on from this, and I know, Neil, you've got to go on to another meeting in a couple of minutes.
I have one
Thank
thing
you.
to say, Neil, let's reach out after this and talk about this from the FAR perspective, because I think there is a fix.
Absolutely.
Okay,
Yeah,
good.
we can tweak this to make it better. It may not be perfect, but certainly there'll be enough ideas that we can discuss. Any other hands up? Okay. Is Belma Andrick, Dr. Andrick, are you on yet? Uh-oh. Okay. Did I see Eric Urlano on? I know that he said he couldn't make it until after 2. Okay. All right. Would you contact Dr. Hendrick and see what's,
I can do it.
okay, good. Let's go to the legislation and
Oh, Terrell's here. Terrell, I want you.
oh,
She knows. Terrell, pardon.
okay, she's not,
We were late.
oh, okay.
Yeah.
All right. Recognize that Terrell Pyburn is with us. Hi, Terrell. We'll be discussing the proviso for a statewide study of recovery residences and other community housing in a couple of minutes. But let's then skip down to the legislative initiatives. Hopefully, Dr. Andriek will be on and can talk to us about the addiction stabilization unit after.
She's not coming. Dr. Andrew.
Is anybody coming to talk?
No.
Sorry that we're having a real-time glitch here, but I believe that we're not going to get an update on the addiction stabilization unit today. I apologize. The meeting will be shorter, however.
Ha ha ha.
Okay,
They know.
nothing wrong with that.
Yeah, yeah.
Okay. We don't have anybody on the call from DCF. I thought that we were going to have the Southeast Region rep Shayla Brown, but apparently she's not on the call.
No DCS.
We have a number of statutory glitch amendments that we have in your handouts. I've given you a lot of resource material as well as the statutes themselves. So, and I believe you've got bullet points. As well. These go along, I think, with the Senate bill 210. We have 210, SB 210 and HB 295 have both passed. The Senate bill has passed its first committee stop. I don't believe the House bill has gone to any of the committees yet. I'll be in Tallahassee the first week of March, the beginning of the legislative session. I hope to have a meeting with the Assistant Secretary, Substance Use Disorder, this space, treatment space, because I think we have a disconnect between what we're trying to do and maybe what the department feels should not be done or should be done. I'll leave it at that. You do have your Department of Children and Families legislative bill analysis. This was for SB 210. I invite everybody to look at the General Counsel's review and the additional comments. They, I don't really know how to respond to them. We have a certification system in Florida. It's here. If you're a provider and you're taking a referral or referring somebody, you have to be a certified recovery resident, period, the end. We have 7,000 beds that are certified. We have a lot of people who are obeying the law. We have one loophole we're trying to handle in the legislation, and I don't even know why it's getting pushback, because a community residence is a community residence. The communities need to be protected, but more importantly, the people living in the houses need to have a certain degree of oversight, rules that will protect them from abuse and manipulation and exploitation. But anyway, section 1 in your legislation, and let's look at SB 210. Instead of the bullet points, why don't you pull up SB 210? Okay, please. These should have been in your packets. And here it is. Yes, it is. So we don't, it's not real major. The stuff this year is not major. Some of it is, can be considered major because the system is not working the way it was designed to work and the way the statute requires it to be worked. So section 1, okay, there are a number of amendments or additions to legislation the Sober Homes Task Force and also the State Attorney Addiction Recovery Task Force, many of you have brought to our attention, and law enforcement has brought to our attention, that there are a number of facilities that market, come to our facility for treatment and you can smoke marijuana. What could possibly go wrong with that? Couple of things to note. Number one, marijuana is not FDA approved. It's not legal in federal law, but in a clinical sense, it's not FDA approved. It cannot be prescribed. A medical marijuana card is not a prescription. In Florida and in many other states, there is an exception for the use of marijuana, and you can get a doctor to recommend the use of marijuana, but it is not a prescription. In a number of well, let's look at section 1 and 2. And then we have, in addition, we've added marijuana to the prohibitions for FAR in terms of a certification of a recovery residence. Okay, so sections 1 and 2 deal with licensing. Licensing is supposed to require best practices. We wrote it, greater minds than I, put it into law in 2017 for the first time, that when you're looking to license a treatment facility in the addiction space, you need to make sure that they use best practices, best clinical practices. What a novel idea. Well, it's in law. Marijuana is not a best practice. And that marijuana is not helpful with everybody from Dr. Simonides and FSAM and on down to SAMHSA doesn't acknowledge marijuana as useful in the treatment of substance use disorder. Alcohol is legal, but you don't drink alcohol in a recovery residence or at a facility for the treatment of substance use disorder. So it seems pretty obvious, although there's nothing in law or rule specifically that prohibits marijuana from its use in a recovery residence that's certified or a treatment facility. So there are treatment facilities that are marketing the use of marijuana. I believe, and not naming names at all, but that is an inducement for a marketing campaign. Hey, come to Florida, come to treatment for opioid use disorder, but you can smoke marijuana. That's an inducement. Right now it's illegal. It is a legal inducement. But make no mistake about it, there is no study that justifies the allowance of use of marijuana for clinical purposes within a treatment structure for drug use, substance use disorder. So sections 1 and 2 merely ban alcohol, marijuana, illegal drugs, and the use of prescribed medications by an individual other than the individual for whom the medication is prescribed. Now, there was a kind of there was a number of people who said, well, this is going to be confusing because people think of medical marijuana as a prescription. I even had a legislator call me up and say, well, wait a second, but you can use it if it's a prescription. I said, but it can't be prescribed. But in order to avoid all doubt, SB 210 just yesterday amended the legislation, the proposed legislation, to add a sentence at the end of, which is up on your screen right now. For the purposes of this paragraph, marijuana includes marijuana that has been certified by a qualified physician for medical use in accordance with S 381-986. So in other words, it includes marijuana cards. There's no doubt now it should this legislation pass, which I sincerely hope it does, that'll be the end of medical marijuana or any confusion about medical marijuana use in a recovery residence or a treatment facility that is attached to a recovery residence or refers back and forth. Now, NAR standards already prohibit marijuana. So one of the reasons this legislation has been introduced is because we don't want FAR to get sued because they can't certify a recovery residence if they're using marijuana in there. And we have some pictures showing a real awful house that that is one of these houses connected to a place that allows marijuana to be used. You could never certify that house based on the pictures for cleanliness alone. But anyway, we don't want FAR to get sued because DCF doesn't require it in the licensing. And therefore, there's a double need for this, not only for clinical purposes, but also to protect FAR because FAR can't certify with the use of marijuana inside the home. Okay, I see a hand up, Jeff Lynn.
Thank you, Al. I know that you don't have jurisdiction in Broward County, but we are all aware that this issue seems to be pervading in Broward County more than Palm Beach. What is your opinion on our collective ability, be it the statewide prosecutor or whatnot, to investigate going forward providers that use marijuana as an inducement?
Well, Jeff, thanks for the question. I think what we need to do is pass legislation so they can't do it. They're not under color of law. I don't think the statewide prosecutor can prosecute anybody who's using medical marijuana at this point, because DC has licensed these facilities knowing, or at least becoming aware, because I've made them aware of some facilities. But the response that I got was that it's not in law or in statute, so we can't not issue the license merely because marijuana is used. So there's no law enforcement involvement at this point. Let's change the legislation. Yes, Dr. Simonides, you have your hand up.
Yes, thank you. Yeah, as per our discussion last time, I did brought them the issue to FSAM and ASAM, and they're all on board, of course, with what we stand for, and they are willing to issue any kind of statement or any kind of document that would support the inappropriate of the use of marijuana in sober living.
John, if you could get that statement to me as soon as you can, because the legislation is already in in the committees, and the session starts in the second week of March and lasts for 2 months. That would be huge. And if you have anybody from FSAM, say, that's in Tallahassee, that is promoting any legislation that you all are promoting in this year's session, if they could also perhaps show up to a committee hearing or two and just wave in support, that would be awesome. So thank you for that.
Tallahassee's lovely this time of year, Doctor.
Yeah, it'll be nicer in March than February, but yeah, it's lovely. That's great. Thank you, Dr. Simonides. Okay, let's move on to the next section, which is section 3. Back in 2017, a law was passed, and I've mentioned it earlier. It was a first for Florida. Florida was the least regulated state in this field before 2017, 2015 to 17. In 2017, after the task force was begun, in that session, one of the things that the legislature did was it created a process in law for fines if a provider is violating some of the requirements of their license, that they can be fined. And there are 4 classifications. 2 are fairly benign, and they just need to be corrected. But the 2 that involve the health and safety of the patients are mandatory fines that, once identified, need to be imposed and need to be paid by law. For 7 years, actually 6 years, come July, There's not been one fine imposed and not one fine collected. And the understanding I have, although I've requested and not received anything in writing, but the understanding I have is that there is nothing in place. There is no mechanism in place. There was in 2020 rules change, which designated what the fines would be and what those violations would be. Okay, what classification different violations are for different component licenses. Notwithstanding the fact that a system was set up for the fines, apparently there's no mechanism for the collection of the fines. What we're merely asking the department to do is by January 1st, 2024, to have such a mechanism so they can begin the imposition and collection of fines. I do not know what they do with complaints that come in. I do not at this point know whether they're investigating complaints and they're uncovering violations of the licensure requirements and just not imposing the fines, or they're not investigating. I don't know. I hope to have an audience with some of the folks in Tallahassee when I'm there in March. You know, everybody on this task force knows that I'm all about cooperation. I'm all about doing the best for the patients and the best and to protect society and protect people and prevent death. So, you know, whatever needs to be done, whatever we can do, but for God's sakes, there's going to be a mechanism if this legislation passes by the beginning of next year. Anybody have any questions about number 3? Okay. Section 4 deals with 397, 487, voluntary certification of recovery residences. All this does, section 4, is it adds marijuana to the prohibitions in order to receive a certification from FAR. And again, it's not kind of, but it's similar to section 1, section 2, as far as the rationalization and the reason for doing that. Also in section 4, amending 397, 487. There has been an issue. Susan, I would like you to find out from Whitney, because she's the one who brought this to my attention. You know, just verify that there have been complaints. Staff asked me, well, we're adding a second-degree misdemeanor for trespass after warning for discharged people who are discharged from a certified recovery residence. You know, where'd you hear about this? You know, is there a problem? And my understanding is there is a problem, not in Palm Beach County,
Right.
but around the state. And so I just need something from FAR that's going to tell me so I can send it to staff so that they can be comfortable that there is in fact a problem. It's not a huge problem. It's some law enforcement agencies will come to the sober home and they think it's like, you know, some wizard's castle or something where they can't do anything unless somebody, you know, actually is violence or, you know, theft or something. But when it comes to discharging, even though last year we amended the statute to allow the discharge as long as there's a discharge policy from a certified recovery residence, so that, you know, you don't just throw somebody out on the street. I was just told today that there was a place in Maine where they just, in Maine, it's winter, where they just threw somebody out on the street. Just threw them out on the street. I mean, you kill somebody doing that in Maine in February. But a discharge policy means that there's a place for them to go, whether even if it's a shelter or a higher level of care or a relative or a friend, they're going to have some place to go. They just can't stay in the house, because if they're using drugs or are a danger to the health and safety of the other residents in the house, you cannot have a sober home where somebody's using drugs, for example. You just can't have it. It'll pollute the entire house. So anyway, that
will follow up
is
with
just
Whitney.
adding the that as a specific second-degree misdemeanor, so the police who come or called and come to a recovery residence can say to the person, come on, you need to go to Uncle Jack's place, or you need to go to this shelter. or you need to go, you have an opportunity to go into treatment, but you can't stay here. Rather than say, well, there's nothing we can do, there's no law. We can't take this person out and tell them they have to leave or arrest them. Even though they could under the current law, but this is kind of, if there's a half a dozen or a dozen instances where this is used, it may save a dozen lives or more. Anyhow, that's section 4. Any questions? Okay, section 5. Again, it's the use of alcohol, marijuana, illegal drugs in 397-4873, which is referrals to or from recovery residences, and it's a prohibition against marijuana. So that's, again, same theme. Section 5 continued, second part. This is a little more nuanced, and trying to explain this is kind of like explaining astronomy when I was in astronomy class in college. Okay, I didn't really get the physics of the matter, but when you boil it down, there's an exception, there's a loophole, been in there for years, that is allowing one license component, that is day-night treatment, day or night treatment with recovery housing. They have a house that is contained within a license. It's the only such license in the state of Florida that has housing other than inpatient and detox. That's 24/7. I'm talking about it's the only license of a community house where the house is embedded into the license itself. DCF sent out a memo after the law was changed in 2019, where the legislature changed the definition of recovery residence to specifically include day or night treatment with housing residences, provided they're peer residences, which they are. And so DCF sent out a memo, the department sent a memo out saying these residences had to be certified if the referrals came from a treatment provider or another sober home. In other words, another recovery residence outside the license. The word I got from the department was you cannot physically refer a patient within your license. So if a patient comes to Happy Acres day-night treatment with housing, and they come directly and they're marketed in, or they call up and they come into the treatment facility, they're coming directly into that license. And so putting them in the house is not a referral according to the current state of the law, according to the interpretation by the department, which I respect. So what we're doing is we're specifically amending the definition of referral to include the placement of a person in a house that is within the component license day-night with housing. It's closing a loophole. There probably aren't more than 25 programs in the state of Florida. I don't know how many beds, could be many hundreds of beds, depending on the size of the program. There was a day-night with housing program in Palm Beach County that had 2 apartment buildings. I mean, there must have been 300-400, can't remember the name of the place, Susan, I'm sure you do. But it's closed now. But anyway, we don't know how many beds that this affects, but it's a loophole and it's a community residence. So all the reasons why certification is a good thing, all the reasons why a certified recovery residence administrator looking over the house is a good thing to protect the residents of the house from abuse or neglect or exploitation, apply to, just because there's 25 hours a week of treatment at another location, not in the house, and you go home to your residence as opposed to 9, there's no functional difference in the requirement or the need to be certified. I hope, I've been honing this argument because I got to do it to the legislature in the first week of session probably. But it seems like people, it's hard to understand. Well, why are they not registered or certified rather? Well, because the department says they don't have to be. Now, many of you may know that many of these day-night treatment with housing component licenses also house IOP people. They also house people who have been referred from other entities. they're just running under the radar because nobody's looking. And it's much harder to police without having a blanket. You need to certify, dude, if it's a community peer, peer type community house. You need to certify, so all those other under the radar things will stop. Any questions, any hands? This is important stuff here because we're seeing our law enforcement side is seeing in other jurisdictions, if it happened in Palm Beach County, we would have a recourse, and I don't care if it's a misdemeanor, we would investigate. It's not. It's happening in other counties, West Coast, south of us, north of us, where these they're not, path of least resistance. We don't have to certify. Okay, let's move on then to. Okay, the last part of section 5 again is just to say in another part of the chapter where it's appropriate to say, look, and I think this part of the chapter is the $1,000 fine for violating the certification requirement per occurrence. And we're saying, hey, you've got to have, no, this isn't.
Don't go up.
That's the last one. Is that the last one?
This is section 5.
All right. My bullet point shows that the last section in section 5, and I'll give you the lines in the statute 210, which you also have.
Yes, they have that.
All right. Sorry, folks. Oh, by the way, you do have the legislative bill analysis in your handouts from the department on SB 210. And you have the memo that I just referred to about day-night treatment with housing component licenses and the requirement to certify if the referral is from an outside source, an outside provider or residence. All right, well, let me just end by saying that for the purposes of finding violators of the voluntary referral statute, where they have to be certified if they accept a referral or refer somebody to a recovery residence or from a recovery residence, that the department has to have a mechanism in place by January 1st, 2024. Okay, any questions about those legislative enactments? Please, anybody and everybody, I've already talked to Dr. Simonides. If anybody is going to be in Tallahassee or is part of a group that can write a letter to me, and I'll forward it in support of this legislation, I'd appreciate that because they do like to know that it's being supported. The last piece of legislation.
Al. Sorry.
Yes, Terrell.
So I just noticed, and maybe I'm somehow missing it on my version that you sent earlier, but it looks like in Senate Bill 210, that language that was added that you just referenced with regards to a referral to a licensed from a licensed facility was removed. Now, I know I took notes saying that you said that DCF mentioned that they can't make a referral to housing within the license. So is that why that was removed?
No, that was verbal. They never wrote that. I've asked them for a written opinion on this, and I've been waiting two or 3 months and have not gotten it.
Because it appears that what's missing from the bill that you sent around, Senate Bill 210, and maybe it's been updated since I had something saved from January 23rd, and it looks like the lines that we were looking for were lines 99 to 104 on the 4th page, which amended section 397.4873 subsection 4 and added a B. And it looks like what you sent around ends with 3.
Oh, the one I sent around, you talk about the one with the red line?
Yes.
Oh, yeah, the red line was a suggestion from Jeff Lynn. And on how to, in terms of marijuana, is that what you're talking about?
No, it looks like it's missing the crux of what the point was in that legislation. I don't know if there's been an amendment. Hold on. Does anybody else see this?
For some reason, all I have is SB 210, the amendment. I don't have SB 210, the original, which is not helpful for this.
Okay, so I'll take a look at it. You can keep going. I'll look it up on online Sunshine and compare.
Right. If you have any suggestion, if the language regarding the referrals on 397 4873, if that needs tweaking, let me know. If you and we can deal with the legislative staff. I think it does accomplish what we set out to do, which means it's part of the referral process, if that's the one you're talking about.
And I thought it did, but it looks like it's been amended further. So that's what I'm trying to pull up independently. I don't want to hold you up. I'll take a look.
Okay. All right. Okay. Thank you. I don't believe it has, but maybe I missed something. It's been a rough week. Let's talk about the fentanyl test strip bill very briefly. We tried last year. We proposed. State Attorney's Office sent forward proposed legislation which adopted the Arizona law that said carved out the definition of paraphernalia, which is illegal, drug paraphernalia, and any testing, anything used for testing of drugs is illegal in the state of Florida. It's a first-degree misdemeanor. So we sent out legislation. It passed the House unanimously. It was on a Senate bill, but it was stripped from the Senate bill on the last day of session. When sausage is made, you can ask questions. Sometimes you don't get answers, but we're back at it again this year. Senator Polsky has her a version of the statute, and there's another one in the House, and unfortunately, I can't remember the representative's name, but it's been filed. It's already gone through one committee in the Senate, and basically it just carves out an exception because you saw 97% of overdose deaths in 2022, so snapshot number, and 91% in 2021 of the opioid overdose deaths had fentanyl present to the cause. And people increasingly, since it's polluting every drug known, any benzo, even marijuana is in danger. Street marijuana is in danger of being polluted with fentanyl. Anecdotally, we keep on uncovering cases where people buy cocaine, like the 4 cadets in Daytona Beach, wind up overdosing, not knowing that there's fentanyl there. $1. A test strip that costs $1 could be available in CVS, in Walgreens, at Publix, by the pack. It's not to encourage drug use, but for God's sake, if it's harm reduction. Needle exchanges doesn't promote drug use. It's a harm reduction. And we could significantly, I believe, reduce the 6,366 deaths for opioid overdose in Florida in 2021. That's the raw data from the medical examiner's office statewide. We could reduce that by hundreds, if not thousands, by allowing somebody to be able to test a drug that they don't want to die. They don't want fentanyl. If they get cocaine or they get a Xanax pill, they have a test strip that can allow them to determine that there's fentanyl present, so they don't take the drug or they don't buy the drug. It seems like a no-brainer, and hopefully it will be this year. We'll see. Jennifer Webb, you have your hands up, and welcome, by the way. We called you out earlier on, but you weren't here.
Hi, y'all. Sorry, I had a staff call out sick and I had to take their meeting
All
earlier.
good. All good.
I'm really happy to be here. And I was actually at the Criminal Justice Subcommittee when Senator Polsky's bill was heard. And I wanted to mention briefly that Senator Perry specifically voiced concern. And I wanted to draw this to your attention in the State's Attorneys Association, because with the word products instead of strips, specifically what the bill language says, y'all, and it's a really beautifully elegant, simple exclusion in the drug paraphernalia law, is it says excluding. So basically testing equipment is used, intended for you. I'll just testing equipment is illegal, or excluding narcotic drug testing products that are used to determine
Right.
whether a controlled substance contains fentanyl or a controlled substance analog of fentanyl. The word product instead of strips, he got really hung up on, because he started saying, and I didn't have time to clarify. He was like, well, they could buy one of those very expensive law enforcement machines and use it to make sure that they're just providing enough fentanyl to get people high instead of kill them. And so there might need to, and he suggested amending the language, which I think is highly problematic because this language is working well in other areas, but I wanted to bring that to your attention.
Thank you, Jennifer.
Yeah.
From a law enforcement perspective, because that's what we do here.
Yeah.
That's, okay, I'm not speechless. I'm just trying to formulate my words judiciously. Okay,
Yes.
because I don't want to offend anybody. But one of the problems with fentanyl is that every time a drug is cut, somebody has the opportunity to add or subtract something.
Mm-hmm.
Okay. The type of equipment that he's talking about is never the tip of the spear for law enforcement. If somebody has the type of sophisticated machinery that can quantify the fentanyl in a product, you're going to bust them for a kilo of fentanyl. You're not going to bust them for having a misdemeanor offense of paraphernalia. I mean, to make that argument, whatever form, first of all, in reality, nobody's going to have a sophisticated machine to be able to quantify the amount of fentanyl that's in their little stash that they're intending to use, which is the end user is what we're talking about here.
Mm-hmm.
And if they did, so what? It's still harm reduction to the end user. It's still a means of keeping them from dying or overdosing. But as a practical matter, this is a first-degree misdemeanor. Nobody's going to buy a $100,000 machine
To get
so that they
around the
can test
first
the
degree
quantify fentanyl. So that's really the answer, that in the real world, there's no difference. Because a drug kingpin that's using it doesn't care about the misdemeanor. Not going
Mm-hmm.
to get busted on a misdemeanor. They're
Right.
going to get busted for the kilo of fentanyl that they have, hopefully.
Right. And
So that's your answer to that. And if, by the way, Jennifer, if you're in Tallahassee for any of the hearings for the Sober Homes Task Force bill,
I've been paying attention. Yeah.
good. If you could go wave in support or speak and say, hey, this is good stuff, that'd be helpful.
Happy to do it. And promising, it did pass unanimously. And there were some very traditionally conservative members who have voted against other harm reduction strategies who voted in favor of this
Mhm.
bill. And so I think that we collectively and Senator Polsky and Senator Pizzo have done a good job of educating that body, because it wasn't a standalone bill last year. It was attached to
That was attached, yeah.
the
You're right.
other,
That was one of the problems.
the bill that became the mandatory minimums bill. But yeah, so it's really promising. That
Jennifer, the one thing you're going to have to deal with, and what I understand, and I this has come to me third hand through reputable sources. But there was one person who blocked the Senate vote and stripped it out last year. And what you're dealing with is you're dealing with that same canard of, I don't want to help drug users use their drugs. And there is a bias there. I get it. You know, it doesn't help to call people out, but as the death toll rises from 4,000 to 5,000 to 6,000 plus throughout the state, and everybody, not only people that are on this call, but people in the legislature all know somebody who's died. Somebody, some family member or friend of a friend's family member. I mean, it is now, the pill mill craziness pales in comparison to the death toll that's happening right now with fentanyl and fentanyl analogs and opioids. So good luck, fight the good fight. I'll be there second week. Well, let's meet.
Connect. I would love that.
Okay.
Al, may I interject something?
Yes, Nikki, please.
So I brought this up to a couple. I was up in Tallahassee and had a few meetings and brought this up. And from my experience and my conversation, there is a lot more educational efforts that we need to do in regard to this bill, because the handful that I talked to had the more old school thinking that this is not even a harm reduction, that this is supporting active drug users. And it was very disheartening to hear. And so I did my best to talk, but there is some very higher ups that I can talk to you offline about that feel very strongly that against this. And so
Nikki, was that in the House or the Senate?
House,
Oh, yeah.
but I had some meetings, Jen, with some of DeSantis right-hand folks that feel very strongly against it.
I've got
Well,
some.
that's really interesting, because
statistics
I was told that he wasn't going to use that he was going to let the process play out, and he was okay with this bill.
So
I would love to talk to you and coordinate.
Last year it was unanimous in the House, so interesting that it's kind of flipped. But Jennifer, I've got some, and anybody, Nikki, you too. I've got some statistics that we drew from the 2021 medical examiner's report statewide, because anybody can get the raw data from them. One of the problems with that report is if they have multiple causes of death, they'll count multiple causes of death. So you kind of skew the overall numbers by some, and the opioid overdose deaths are the number we have is lower than the number that the state report had, the medical examiner's report. But one thing we got, what I asked our analysts to do was to eliminate all other opioids, but fentanyl and fentanyl analogs, and then start building other drugs that were in cocaine, methamphetamine, amphetamine, benzodiazepines, marijuana. And we have statistics that we drew from that report that shows conclusively that people died, thousands of people died from cocaine and fentanyl analog. Nothing else, no other opioids, okay? It may not be all of them that died from the fentanyl, but the majority probably did. And they weren't looking for opioids. That's why and benzodiazepines on the street, they're polluted. Adderall, there are anecdotal reports of students buying Adderall on the street and dying or going to the hospital. So I think those stats, I meant to bring them today because I already on them, but we'll send them out, and it just shows fentanyl analog presence and drug, and no other opioids. So that should show that this will save lives if people use this strip. If they're not looking for opioids and they die, that person could have been saved with $1 strip that they could have rubbed on the drug and gotten a positive test and said there's fentanyl in here. So yeah, that is the issue. That if it does not pass, it does not pass because of that bias, that old school bias of it's the drug addict's fault, and we're not going to help them. But hopefully hopefully that won't happen this year. Okay,
Now, can I just jump in real quick and
John,
Jennifer,
please,
I
jump in.
apologize if I missed this, but
and then Terrell.
could you just talk about your affiliation with Florida?
Absolutely.
Thank you for others' edification.
Absolutely. And I apologize for joining late. I am Jennifer Webb. I'm the Executive Director of Floridians for Recovery. Floridians for Recovery is the statewide recovery community organization. I'm also a former state representative, and I'm also a person in long-term recovery. So and I lost a family member to the opioid crisis. So this is something that is absolutely one of FFR's top priorities and one of my personal top priorities.
Okay, Terrell, you had your hand up?
Sorry, I forgot to lower it from before. That's all. I did realize the issue with Senate Bill 210. I put something in the comments. Everything's good. Thank you.
Okay. Well, Terrell, this is in your wheelhouse. The last thing we'll talk about legislatively is the proviso, the appropriation to have Dan Lauber do a statewide study so that we can make some sense out of an ADA FHA acceptable method by which we can strike a medium between clustering not only recovery residences, but all community residences, where we can strike a sweet spot between the communities and the residences. Also, so that we can have some degree of protection on these non-medical community residences, so that the residents are not exploited or abused. And Delray Beach and Palm Beach County and let's see, West Palm Beach, Pompano Beach, Fort Lauderdale, all at great expense had to conduct their own study in order to enact an ordinance that struck these bargains, so that in one sense you can't exclude houses, these community houses, but in the other sense you can't just allow them as a matter of right to develop de facto treatment districts and also be flop houses and warehouses, not being abusive or exploitive of the residents. I think that's pretty much it, and I'm happy to say, and I want to pat the county on the back for this, because up until late last week, I thought that the Florida Institute of Government through University of Florida was going to submit the application for the appropriation. And then I found out that they couldn't because they're a university affiliated department, and the university can't do individual appropriations or legislation. So I called the Palm Beach County Community Affairs, Ed Chase. I don't know if Ed tuned in. He is part of this, and also Casey and Todd Von Laren just stepped up to the plate. And within 2 days, they had the paperwork. We were able to put together the paperwork, and I'm happy to say that it got in on time this year. So we have an appropriation request. In 2024, if this passes and we get the study, we'll all be talking about legislation that can give guidance to all the governments, all the local governments around the state, so they don't have to pay. What's the average, Terrell? How much did Delray Beach and Pompano Beach have to pay for their study? $100,000, something like that?
I think it depends, but Delray Beach undertook the study in 2016, so it's been a couple of years. I think that they paid somewhere around 60 to 70,000 once all was said and done, and then I believe some other cities that have undertaken it more recently have paid a little bit more.
Wow, so you can see how prohibitive it is, especially for smaller communities, even if they have a problem with how to deal with allowing the residences in, which they should, and they have to, through the ADA and FHA. And number two, How do you do it while protecting the residents and protecting the community? And this would be a one-shot that would be a study that would enable most communities in the state to be able to pass a uniform, fair zoning ordinance for, in exchange for reasonable accommodation to allow the houses. The houses have to have some kind of, they've got to be good houses. Just use the pejorative, good housing, fair, FAR certified, Oxford houses, that kind of thing. Terrell, do you have anything to add on this? I'm very happy to say it's in there, and we'll be hopefully getting that passed and again getting this process started.
Yeah, I don't really have anything else to say other than the Florida League of Cities was very receptive to it when I presented to them on this concept back in October, and they still are following it and supportive of it. Additionally, though, I do want to point out that they did want to make it clear that any legislation not be something that is sort of preemptive or infringing on their home rule rights, because not every city will necessarily want to put something in place, but it will provide for kind of a template for those cities that do, so that way they don't run afoul of the federal laws.
Yeah, all we're trying to do when we do write this next year, Terrell, all that we're trying to do is to make local communities able to take advantage of the use of this model legislation, model zoning legislation. It doesn't force anything on anybody because you just simply don't have to enact any kind of zoning or land use practice that involves community residences. Okay, any comments? Jeff, you have your hand raised. Of course.
I actually have a question for
This is in your
Terrell.
wheelhouse, dude.
Terrell, before you run, in those, I think it's, I know Broward counties like this, Terrell, and I forget if it's Hillsborough or whatever, that have have maintained countywide land use control in their zoning. Would this be something, at least for Broward on a smaller scale, to get the Broward Planning Council behind so that the Broward County land use plan could change?
That's probably not a bad idea. I mean, Broward County, you're right, they do have kind of control of land use. That being said, I mean, several cities in Broward County have passed an ordinance based on a comprehensive study. Dan Laubert. And so I guess there is some flexibility in Broward County's code. I can't speak as it relates to Hillsborough County. I know that when the Planning Council recently sent around some draft definitions of various terms that included group housing, I made sure to provide some comments so that way there would be nothing conflicting. But it's not a bad idea, Jeff.
Al, just so you know what we're talking about is, obviously we're looking at big picture, but also in Broward County, and I think it's Hillsborough as well. Those are charter counties that have maintained county-wide land use controls, such that your local comprehensive plan and zoning must be consistent and compatible with the county's land use plan. And so what Broward County has done over a period of decades is, if they adopt something in their comp plan, you have to adopt a parallel in your own. So at least for Broward County and maybe for Hillsborough, while we're looking at a statewide process, there is also a parallel opportunity to affect those counties that we know are highly populated and do have a lot of sober living in them to maybe deploy this at an additional level. But just food for thought if you have relationships there in Broward to have that conversation.
Okay, well, we've got plenty of time to get the ball rolling on all this, and boy, it's going to be interesting and fruitful, I hope, writing that model legislation that can be adopted without violating the Americans with Disabilities Act or the Fair Housing Act. By the way, I do want to recognize Jan Toman, who is Project Opioid South Florida. She wasn't on when we introduced at the beginning. Jan, are you still on with us?
Yes, hello.
Hi, welcome. Hey,
Hi.
stop having your meetings in Miami. I'd like to come to one of them,
Ironically, I'm actually checking my text messages right now because my Miami colleagues are at a school board meeting right now, and I'm trying to get the answer. 1 second. I believe Okay, no, they're still waiting to speak, but I believe we're getting the vote to hopefully have naloxone in every school in Miami, which is the third largest school district in Miami. So we're hoping to get that vote for yes today. They're at their third meeting right now.
Jan, do you want to take a minute or two and just introduce yourself and Project Opioid so everybody on the task force knows what it is you do?
Sure. We're a Tri-County initiative, and actually Jennifer Webb is also, we also do some work with her. But it's a Tri-County initiative and we do several things. We have, we're focusing on wellness, as well as distributing naloxone because it's important to be proactive. So we have a couple different initiatives that I can describe more if anyone's interested in emails. One is the Chant Plan, which is a tax credit for any companies that would like to promote wellness within their corporation. And then we have another one that's Fellowship RCO that does something similar where they can go in and have employees discreetly, if the employee does not want to go to their bosses or tell anybody else they think they might have some sort of problem, whether it's alcohol or opioids or whatever, then they can discreetly follow up with Fellowship, who will help them find the resources they need, whether it's just therapy or it's in-house treatment, starting from the beginning so that we try to catch the problem before it gets too bad. Another thing that we're really focusing on, I'm not sure if you're going to be able to see because my background kind of messes it up, but we have these opioid kits, which we are distributing. We've distributed over 50 in, let's see if I can get it on here. And I don't think it's going to show up, but it's like a first aid kit and it holds naloxone. It has screws in the back. And we've distributed about 50 in Broward so far, and I'd like to get more up in Palm Beach, and we're distributing in Miami also. If anyone is interested in any of that, we have them in a lot of the hotels here in Broward. I've taken them to the Marriotts, the Hiltons, some of the smaller hotels on the beach, because as we know, the tourist industry here is huge. So when people go party, they party in the nightclubs and then they go back to their hotels and party. And a lot of overdoses happen there. So the nightclubs here and the high tourist areas like Las Olas, a lot of those managers have put them in either the hallway, a private area in the hallway close to the restroom, or even in the restroom. Some prefer to put it in their office just if there's an emergency. But we do have a grab and go sticker on there. So we don't want it to just be used for emergency. We work with BSO also and pass it out to the most high risk gas stations like racetracks and smaller convenience stores in the high risk areas. And we're having a lot of positive feedback that we're saving a lot of lives. So if anybody has any questions, they can reach out to me and I can get them the kit or the naloxone if they'd like.
Awesome. Jan, I take it that once test strips become legalized, that you'll be, that'll be in your wheelhouse as well.
For sure. Yes.
Okay.
Thank you so much, Al.
Okay. Is there anybody else that's on that wasn't on at the beginning that you want to introduce yourselves? Because I know that there a few people did show up after we did the introductions. Okay.
Just jumped on, Al. It's Eric.
Oh yeah, Eric, you're it's showtime for you, dude. Matter of fact, let's segue into you. I called Eric. Eric is Integrity Billing. Eric, I think you've been on the task force since the very beginning in 2016, July, right?
Yes.
Okay. And an article was sent to me. I think Maureen Killian sent this to me, and it was about private equity getting into the treatment space. And the first thought that came to my mind is what could possibly go wrong. And then I read the article and it was obvious what could possibly go wrong. But I want to talk to Eric because he deals with billing and he deals with many providers. And there's some good, there's some bad, but I want it straight. So Eric, do you want to kind of start the conversation about private equity getting involved in treatment?
Well, there is the good and there is the bad, and I'll keep my opinion short and bring to the table what I can to hopefully aid you in what you're taking on and seeing. You know, let's face it, we're in a capitalist society. High prices and low overhead equals big business. But the problem with the private equity is they're charging high patient fees without guaranteeing access to evidence-based care. So I spoke to some mentors of mine, and it really kind of boiled down to two questions about the PE firms. Do they have a background in healthcare? And if they do, what is their willingness to learn? I would say that a PE firm whose business model is healthcare can be best suited to our industry. PE with their fiduciary-backed investors are legal and follow rules like the anti-kickback, the federal fraud and abuse laws. You know, let's face it, 20 years ago, money was needed and corners were cut by owners. Now we have an oversupply of beds and private equities injected cash, and there's a lot of money to be made. You know, right here in Palm Beach County, we have the juxtaposition of two large treatment organizations that are backed by private equity money. One leaves a lot to be desired, that private equity firm. This other company, they are just a great company with a great private equity firm. Not-for-profit boards, I don't think they're an answer. They have limited skin in the game, and do they really have time to care at the end of the day? But right now, what we're seeing with private equity, I think, is not necessarily dovetailing with high quality treatment, and that's the problem. So that's about all I have.
Thank you, Eric. I want to open it up to hear your thoughts. If you read the article, and I mean, when private equity or a hedge fund gets involved in something, there's a profit motive that may not be there with private ownership. There's a hands-off as far as the ultimate governing board, say, in general terms, and the article talks about programs being slashed because they're not profitable within the treatment of an individual patient, and people let go because they can hire people who are less of a lesser stature or education in the treatment space. They can get by with a tech instead of getting by with a certified addiction recovery specialist. And the article was pretty much negative about it. You know, one size doesn't fit all, but I'd like to hear from some on the task force as to how you feel about this. And I don't know that there's anything that we as a task force can, or Dave Ehrenberg as a state attorney can do. It's private, you know, capitalism is capitalism, and that's our system. And you know, in the healthcare space, I believe that this is present in the primary care space. But anybody want to chime in? It's just something that we need to keep an eye on.
I'll chime, Al. So specifically in Florida anyway, Florida's medical models, hospitals are run largely by for-profit institutions. I am an advocate of nonprofit healthcare, nonprofit substance abuse care, and I do think that the boards, because I'm on a few, are very much involved in a nonprofit. Having said that, your point is well taken, right? That, I mean, this is America and people are allowed to be capitalists. So the answer to me, once again, is there needs to be very clear standards of what's expected of a substance abuse treatment facility and what's expected of a recovery resident. If we have that, then I don't care who owns. I mean, it won't matter because the standards will apply whether you're at some fancy schmancy place on Palm Beach or you're in, you know, somewhere not so fancy. And and the standard should be the same regardless of who operates the facility. The care should be the same, the licensure should be the same, and the oversight needs to be more. And if I could continue on about the value of civil litigation and tell the Connie Francis story, but you'd all shoot me. So anyway, the point is that, like Dr. Simonotti's Florida Association of Addiction Medicine, all these groups and all of us are the ones that are going to enforce it, whether it's a private equity firm or a bunch of people who put a few dollars together to open a place. Or it's state funds.
Yeah, but I think it goes beyond private and not private. When you talk about equity, capital, or hedge funds, you're really going, there's a third layer. Because, I mean, there are plenty of for-profit providers that actually are hands-on and have lived experience or are invested in the space. And it doesn't have to be nonprofit, but if you get to the point where you're doing things for shareholders and not for patients, that are divorced from the actual boots on the ground, that's where, and again, there's no solution to this other than, you know, maybe some of these private equity firms decided to get involved because of last year's gravy train, which is like urine, testing, which paid millions and millions and millions of dollars for something that was clinically either unsound or unnecessary, but not necessarily illegal if done right. And now there are new whack-a-moles popping up, new innovative ways of billing for things that may or may not be used within the treatment space. But you know, just wanted to have the conversation. Anybody else want to chime in?
Dr. Moran.
Dr. Moran, okay, you had your hand up?
Yeah, thanks, Al. I just wanted to point out that DCF mandates evidence-based practice. So I think, Susan, that's one way we can help to regulate and ensure that patients are getting proper care. I had a question for Eric, and that was, do you happen to know if these firms, the individuals working in these private equity firms actually require true medical directors in the programs?
I mean, they have to, but under the licensure,
Yeah,
you can't have a licensed substance abuse treatment facility without a medical director. You know,
That's
one
right.
of the things that would help is a further definition of who can be a medical director, because I have litigated cases where the medical director was a pathologist.
Well stated, Susan.
But
Yeah,
none
that's
of
it. As simple as that. I have also in a case now where a patient went in who didn't have a substance use disorder problem, and her insurance was paid for essentially 5 weeks of outpatient, $650,000. So I get it. I mean, I just saying there's a way. Part of it is making the physician, you know, get us to real clear standards and real direction as to who's in charge of what. And
But
well, it's not going to go away. It'll come out differently. But
there's no requirement.
Yeah.
I'm so sorry, Susan. There's no requirement for a medical director at the PHP, IOP, or OP levels of care.
No, that's not true. You have to still have a medical director of
Right.
under the DCF regulation.
Only for residential, inpatient, and detox.
He's correct.
Oh,
You need to have like a medical person that you refer to, but you don't need a medical director as part of your required list of qualified persons for your licensure. Dr. Moran's correct.
so you're telling me, fellas, that an IOP, standalone IOP, does not need a medical director?
That's correct.
Okay.
You need to have someone you refer to. I forgot what the terminology they've used, but you don't need a medical director. You do not need anyone with any kind of psychiatry or anything other medical to qualify you to get a license. That's correct.
Jeffrey, the term that was used was medical consultant. However,
right.
the recent rules published have removed the term. So that's no longer required either.
That needs to go back in, but Al, they all
No.
need to have medical
No,
oversight.
well,
Yeah.
Al, I raised my hand because I wanted to jump in just for a reality check on things, which it comes back to the workforce is, from my understanding of being in this space for 13 years now, is that, you take the population of people that go to medical school, and of that population, how many want to be psychiatrists? And I understand that psychiatry is not viewed as the highest and best career in medicine for whatever reason. And then of those psychiatrists, how many go into addiction medicine, even a smaller subset? So I think that while we all want, and there should be an addiction psychiatrist running or directly associated with all these programs, I don't think the workforce is there. I don't think the incentives are there for that workforce. And I think that's a huge problem. We don't incentivize it. We don't do things in our society, both economically to make it worth their time to go into that kind of medicine as opposed to plastic surgery or orthopedics or anything else.
Is
You know, and so
there-
We
it's just,
do.
Yeah,
That's
before we
not
go,
true. I mean-
before we go on with this conversation, let me just throw one thing out there, question. Is there a comparable level of care in primary health that doesn't require a doctor?
Like PT.
I'm just thinking parity here.
Al, because this isn't healthcare under state statute. I know this is funny. This is not
Right.
healthcare.
You've answered
This
my
could
question.
very-
You've answered my question. Okay.
Yeah,
thank
this
you.
could easily be fixed. We've said for years now, Al, long before the task force, we've said that if you add the three simple numbers of 397, chapter 397 to the medical statutes, we would have fixed all of our problems a decade ago.
Yeah.
But
I saw a hand up. Oh yeah, Jennifer, you had your hand up.
Yeah, I was in other areas where corollary to the hedge fund, where it seems to get in the equity investment, where problems seem to arise is when they buy up franchises, when they buy up multiple places. And that's when quality, and I think I've read one study that's what the point where quality starts going down, because they've realized how to squeeze more nickels out of whatever operation that they're starting to invest in. And so I think this conversation, especially of identifying where they could cut costs, is that you could reduce the likelihood for bad apples coming into this sector by being sensitive to workforce constraints, but also tightening some of those requirements so that you can identify, oh, this is a place that they could easily cut costs because the statute's not there, the requirements aren't there or whatever.
All right, thank you. Dr. Simonides, you had your hand up.
Yes, thank you. Group homes probably would be the closest thing that they do not require having a medical director. Also assisted livings, they don't require that either.
Okay, thank you. I want to we need to move on. We have Whitney Van Arsdale here. Going to get some data from OD2A, but I want to just touch on something that Dr. Moran said at the beginning of his statement about oversight, about the key to being able to keep the bad actors at bay is to make sure that the quality matches the statutory requirement of quality. And I got to say that we need to get the attention of the department. And I say this, and I said this in 2016 when we first started and we were talking about ACA taking over, making this healthcare as opposed to families, because 50 years ago, they wanted, where they put behavioral health was in the church and in the family. And so DCF or whatever, they had a different name back then, but the department that handled children and families was a department that handled behavioral health. This is medical, it is not behavioral. But with regard to the department in 2016, everybody wanted to beat up on DCF. Everybody in both task forces wanted to beat up on DCF because they were in 10 years, they hadn't revoked or suspended one license, or maybe one, in 10 years in the state. And things were out of control. And for a couple of years, it was going in the right direction in terms of oversight. But I said it then, and I'll say it now, DCF is underfunded when it comes to oversight. DCF is funded to license, business, business, business. And they're not funded to actually overlook and oversee and make sure that once the boxes are checked off and everything is Hoyle so that the license gets processed, that the treatment actually is quality treatment under the law. And I don't mean a treatment, I mean above, where the law requires it to be. Best practices, actions, referrals to uncertified recovery residences. I don't know how many complaints have been processed by the department in the last 7 years. I only know that there's been no fines imposed or collected. I know they don't want to be in housing. They never did want to be in housing. They just assume that the day-night treatment with housing go away. At least 2 years ago, that's how they felt. But because of the forces in the industry, they couldn't buck those forces. So they're stuck with being a housing overseer for that one license component. But if they don't, as Dr. Moran said, alluded to, if they don't do their job in overseeing what actually happens, as opposed to only making sure that the license is that there's an 80% or whatever success rate in terms of the license application or renewal, then we're going to be nowhere. And I feel for them because they're full of FTEs. No, I'm sorry, they're full of OPS workers. They don't have full-time employees. They don't have the budget. They're not going to ask for the money. At least they haven't, and I understand why. I don't know how to get through. If anybody here knows how to get through the department and to the governor to say, look, there's really not that much that you need to do, but you do need to have somebody doing, you have the ability to do a spot visit without announcing your intentions. How many of them have been done? Apparently in Palm Beach County, none in the last year or two. So until that happens, we're going to be chasing our tail, and every year we're going to be imposing legislation that is going to be very nice because it's there, like best practices in licensing, but is more honored in the breach than in the observance. So, I'm trying to keep my cool here. I'm going to Tallahassee, and I hope to have an audience with the assistant secretary and just say, hey, I get it. You don't have resources to investigate, but how do we get you the resources so that you can do your job, not only licensing, but also maintaining the system in a way that helps people and saves lives and encourages recovery instead of relapse. So anyhow, sorry, I do get somewhat possessed on this issue. Anybody want to comment on that, or anybody has a better way to approach the mousetrap? But we will never, I realized it in talking to staff and not getting any answers from the department, reaching out to the department and saying, what is your opinion of this? What is your opinion of that? How can we fix this? And not getting any response that's part of the problem. We can pass good laws like the certification statute, and all we have is FAR enforcing it. We don't have the department enforcing it. Until we do, we're going to have 6,366 deaths and rising in the state. So keep posted on my progress. I'm not overly optimistic, but I'll go against that stone wall as many times as I have to because I'm crazy.
Al, it's Jeff, just if I can have a second, we've talked about this, but for those who don't know, the current executive team at DCF for substance abuse mental health are all people that came over from ACA for the Agency for Healthcare Administration. So they've been looking at DCF in a good way from an outsider's perspective and trying to figure out how they can start to make everything more clinical and to be more of what we all want it to be. Part of the discussion is money, part of it's existing bureaucracy, part of it is direction from, the governor's office. So, there is some light, and I've said this before, DCF is filled really with wonderful people doing God's work for low pay. And we haven't been beating them up. But I do think that there actually is progress being made, albeit not fast enough for our liking. I think this task force has been in existence for 6 years, but a lot of us have been dealing with it, DCF for many, many years longer. So, there's a lot of good things happening at DCF in Tallahassee. It's just they're not moving at the speed that at least we in South Florida need it to move. And that's just, I think, the makeup of our state and how we're different states all boiled into one. We've always heard from day one, the sober home thing, it was a South Florida problem. We all know that, we heard that. Which is why we were grateful that legislation passed. But Terrell knows as well as I do that early on, when we were trying to grapple with flop houses, that we were getting nowhere, because at Tallahassee, they said, well, it's a South Florida problem, not a statewide problem. So, baby steps. So I don't want it to be all, I appreciate the rant because I rant every time, but I do want to give another shout out to DCF and the people that are trying to make a difference, because certainly I don't think, I think they've chosen to work there as opposed to being forced to work there. So I think there's progress being made.
I hope that a change is coming, but you haven't mentioned anything concrete in the last year. I've seen nothing concrete in the last year, but I hold out hope, and believe me, many of you have been on this task force for years, and that what we try to do is we try to bring the silos together. We can't do this alone. We can't do this in our individual silos. I'm just venting because of the run up to this particular legislation this year. We have been ignored. When I say we, I mean the state attorney addiction recovery task force has been ignored, dismissed. There hasn't even been a conversation. The representative is not even on the call today. I'm not going to shrink from a fight. I'm not looking for one. Just because somebody came from ACA, until there's concrete steps that are made to make this a better system, then you got to. Jeff, I hope you're right, 100%. And I hope that they're going to beef up their oversight. They're going to take seriously the clinical requirements, that there be site visits, that there be, everybody can't be obeying you're saying that there are, I want to say, I just did the numbers. There are 3,077 component licenses in the state of Florida. Roughly the same as there were in 2018, a little bit about 100 fewer. It's been moving around. It's been going up the last couple of years. You can't tell me in 3,077 component licenses that there hasn't been one bad actor out there that needs oversight, that needs to be fined, that needs to be called to task, that needs their license to be suspended or revoked. And the past 7 years, there's been nothing. And the past year, there's been nothing. So, I'm sure my words right now will not endear me to the department, but at this point, I'm so frustrated, I don't care. I don't care. I mean, they can ignore me they can ignore, I don't want to make it about me. They can ignore the task force, which is really, it's not me. You know, this is Dave Ehrenberg's task force. You all are volunteering your time and you've been doing a yeoman's job, and we've been passing good legislation for years. And if they choose to ignore the legislation, there's not a thing we can do about it except to say, okay, call it what it is. So I hope you're right. I look forward to meet in a future meeting saying, Jeff, man, you are Obi-Wan Kenobi when it comes to your prognostication of a turnaround in terms of clinical oversight in the department as opposed to just being a licensing agency.
Al, can you walk us through, someone messaged me and asked the phone number to call, but can you walk us through what happens when someone makes a call? Like how that's investigated, what happens? Like if someone says this person's doing the wrong thing?
Anybody here can make a public records request of that information, I suppose. I'm not there yet, but I'm contemplating it. You know, we need to know. You know, I made a records request to find out where the component licenses were, where they're moving around the state. We had a study 2 years ago, informal, not peer reviewed, but how many recovery residences there were around the state as compared to intensive outpatient programs. And we determined that Jacksonville, Orange County, some counties on the West Coast had way too few certified recovery residences. So we know that they must be referring to uncertified homes, the providers in those areas. You know, if there's no oversight, and FAR has less resources than DCF, but yet they're doing more oversight.
For sure.
So anyway, Jeff, I look forward to saying, boy, you know, Crow, if you cook it long enough, Crow can be digested better. Okay.
Al, I would add one more thing to this.
And we got to get to OD2A. So
Okay, one
more.
second.
Okay.
People can call DCF and make a complaint, right? I mean, I have a lot of DCF licensing file where there's complaints, but there's no action in response to the complaint. But I think the more people complain about a specific place, the more likely they are to investigate. So I would encourage everyone who has a complaint to report it. It does have a cumulative effect in my observation.
I had called Whitney because I wanted to know if she had logged how many complaints she's made to DCF on certification issues in the last year, the last 2 years, whatever. And you know, unfortunately, she's down under the weather. So, but I agree. Right now, we don't know. We don't know what we don't know. Okay. Oh boy. We just had DEA show up. Well, let's get to OD2A and see if we have enough time for DEA to do their presentation. We had them all earmarked, but I thought they weren't coming. So let's get to Whitney Van Arsdale. Whitney.
Hi, Al. How's it going? Thank you so
Sorry,
much for
sorry I took
having
up
me.
15 minutes. Sorry.
No worries. I actually wasn't aware that I would be updating today, so I don't have anything formal prepared. Just a couple
Okay,
updates.
so we'll do you next 2 months. In 2
Oh,
months.
perfect.
All
Perfect.
right. But let's put it this way. You still are on the warpath, right?
Oh yeah, we've collected over 3,000 medical records last year. There's been some changing definitions for overdose and syndromic surveillance, so we've had a lot to talk about here at the health department. But yeah, we're working to get out our next report as quickly as possible for you all.
Awesome. Thanks, Whitney. And so you'll be on the agenda for the April meeting, April 19th. Okay,
Sounds good.
Ernesto, good to see you. Haven't seen you since you made the presentation earlier at the Mandela Healing Center.
Yes, good afternoon. Glad to be with you guys today.
Okay, so why don't you introduce yourself first off?
Absolutely. I'm Ernesto Garay. I'm an intelligence analyst with DEA by trade and a supervisor by fate. I'm a 31-year veteran of the agency, and I'm currently the collection manager. And as such, I have the oversight of keeping tabs with the strategic picture in the state of Florida. We have 14 offices across the state. So I'm the guy that is looking at 20,000 feet, looking down and keeping tabs of the dynamics of how the drug trade is shifting at any given moment over time. I've been asked to give you a very short presentation. I know that time is of the essence today. It's very targeted. I'm going to be emphasizing the situation with fentanyl. I'm going to give you some historical perspective, but I'm also going to come down from the national level picture and provide you with more specific information as to what we're seeing in Florida right now and how that is impacting communities. I believe I can go to the presentation in between 10 and 15 minutes.
Okay.
Quickly. And that way, at the end, if folks, they have specific questions, I'll be glad to address them. I was going to ask you, Al, do you have the presentation there, or you want me to go ahead and upload it?
You go ahead and you share your screen because we didn't get it yet.
Oh,
yeah. And if you could
I
send it to
thought,
us,
yeah,
we never got it.
that's not a problem.
But
Not a
Ernesto,
problem
if you
whatsoever.
could send it to me after, later today or tomorrow. So
By
because
all means,
we need to put it up on our website with all the other attachments.
by all means.
Okay, thank you.
Can you guys see it?
Yep.
Okay. Listen, folks, listening to you guys today, this afternoon for the last 2 hours, it's been fascinating. And in this slide that you're seeing right now, you can tell the importance and how stark is the picture of the problem that you're trying to address. During 2021, we lost like 3 times the number of people that we lost through firearms. The same thing for suicides, even car crashes that are a common problem. No matter where you're in the nation, even that we surpass through drug poisonings, okay? But before we start talking about fentanyl, I briefly want to just bring you down memory lane so we can discuss what is happening right now. Between 1990 and 2010, folks, we had a very standard paradigm regarding heroin in the nation. You will see that in the map, there is like a purple line that is to mimic the Mississippi River. Through investigations and through intelligence and through buys of heroin that will be due during those years, primarily metropolitan areas initially. We knew that everything east of the Mississippi River was completely dominated by Colombian trafficking organizations. They own the heroin market. They own it here in Florida. We knew that. And west of the Mississippi River, it was primarily Mexican organizations. And initially it was like black tar, but eventually they began to produce Mexican brown. And that was the paradigm that existed rock solid for 20 years. Once we reached 2010, that's when everything started going south. That was the last year that we could tell you that Colombians still own the market in Florida. But then during the immediate decade, as it was happening in real time, we began to see Mexican organizations encroaching on what was traditionally Colombian-dominated heroin markets right down here in Florida. And we began to see Mexican heroin actually popping up substantially in many of the markets across the state. And then later in the decade, that's when really things started to go south. And in 2018, we knew that we had a problem. And we actually began to see that across the nation. This is the national level picture. You see the yellow graph in a downward trend, that is heroin. And you see the bars increasing over time to 2022, that's fentanyl, okay? And that's fine, this is the national picture, but I really always like to give you guys a better perspective because we wanna know what is happening in Florida. We have a program that is called the Heroin Domestic Monitor Program, and it's nothing fancy. It is a program that we get funding, and then we use that funding and we give it to undercover agents or give it to informants to go down to the street and conduct buys. The samples that are bought during those buys, they are not for investigative purposes. We send them to the special testing lab in Virginia, and they actually do an in-depth analysis to tell, and they can tell you where the opium poppy was grown, what process was used to manufacture the heroin, and so on. And this is a view of geoprobe buys that we requested approval to do in 2019. Everything that you see in black font is actually heroin, and everything that you see in red is fentanyl. And at that time, this is just the year just before the pandemic, it was pretty even, half and half heroin and half and half fentanyl. Let me show you 2020. You begin to see more red, less black. And this is 2021. When I show the presentation that Al alluded to in December, this was the last slide that I had available. This is 2021. You definitely see more red. And this is 2022, the year that just concluded. And all you see is essentially red. Actually, in this last round of buys, there were only 3 that came back with some heroin. There was one in the Pinellas area that turned out to be fentanyl mixed with Mexican heroin that was actually manufactured via the South American style, like the Colombians do it. And then on the East Coast, we had 2 samples that came with a trace of heroin, but it was even insufficient to determine where it was manufactured. I would bet money that it was also Mexican heroin. But you can see that in essence, what used to be the heroin market in Florida has totally changed, and not for any way better. On the contrary, we got a huge problem. There is no heroin in the state, for that matter. Essentially, everything that is being sold across the state, and the people that go and buy it, and they're being told, yeah, I have heroin, they're being sold either fentanyl or a fentanyl analog. And this information proves it. The fentanyl that we are encountering here is illicitly manufactured in Mexico in multi-ton quantities. Mexican transnational organizations are importing precursor chemicals from China by the tons. They're coming into Mexico. During the pandemic, all of their labs that primarily they had manufacturing methamphetamine, they switched them around and they began to do both. Not only methamphetamine, but they were mass producing fentanyl. That fentanyl gets across the border, it gets smuggled. It comes in a myriad of ways into the state. It comes in hidden compartments on vehicles. A lot of that fentanyl is also once it's smuggled across the border, is being mailed and shipped from California, Arizona, New Mexico, Texas, and it's coming directly to your doorstep via the postal service. And it's overwhelming trying to interdict those parcels via the hubs in the nation. But you also see that is troublesome for us in Florida. There is a line in the map indicating that there is a movement of fentanyl from the Dominican Republic directly into South Florida. Mexican transnational organizations have set up shop in Dominican Republic. They have recruited Dominican chemists, and they're also manufacturing fentanyl in Dominican Republic and using traditional routes to smuggle in the past cocaine, heroin for that matter. They're using the same routes to bring in fentanyl, not only to South Florida, but also to the Northeast. And this is the problem, folks. What we're talking about now, at present, this is now 2023, is not fentanyl in powder, okay? The paradigm shift that we're seeing now is that Mexican trafficking organizations are mass producing fake pills. Initially, they started with oxycodone. What you see in the slide at the top is an authentic oxycodone pill. What you see at the bottom, it is a fake pill that was manufactured by Mexican TCOs, okay? For the layman, for anyone for that matter, that is looking at these pills, there is no way that you can actually detect that there is a difference. And this is how they started pushing it. Mexican organizations have become a lot more creative with marketing. They are now producing these pills in all kinds of shapes, colors, and forms. The sample that you see there in the slide, that was the first seizure of what commonly is known now in the street as rainbow fentanyl pills. That seizure took place in Miami-Dade County, and it was by sheer luck. DEA was assisting Miami-Dade PD to do a search warrant on a resident, and during the course of the search warrant, they came across his pills. This is now all over the nation, and this is now being produced in mass quantities. The problem is so bad, to give you some facts, last year, the year before, 2021, 4 out of 10 pills, such as this, they contain a doses of at least 2 milligrams of fentanyl. That is a dose enough that is a deadly dose. It can actually kill people. Moving forward to last year in 2022, we now know that 6 out of 10 pills actually have a deadly dose. So it's becoming now more prevalent. And remember, these people, they are not quality control folks. Once they send a batch somewhere and they end up killing a bunch of people, they just go back and switch the recipe and they continue to produce. If you would like to know why they're doing this, the reason is very simple. The pills that you're seeing in this picture right now, it cost the Mexican TCOs in Mexico to produce them. It costs them 40 cents a pill, okay? Once that pill gets smuggled across the border, it may be sold between $6 and $10 on the US side of the border, but by the time it makes it here to Florida, it may command upwards to $20 a pop. When you do the math, the chances of profits, they're just out of your mind. I mean, it boggles the mind. They're making a killing, literally about killing people, but they're making a killing, making money. And this is going to be the wrap up. They're not only doing this with fentanyl, they're also doing it with methamphetamine. Just in case you didn't know, I heard early on in the meeting, somebody alluding that when they're talking to people that are going for services, they're indicating that they're doing meth and molly. And that is correct. We're getting overrun by meth. To give you some facts, 10 years ago, a pound wholesale of meth in Florida cost anywhere between $28,000 and $32,000. Today, a pound of meth, especially down here in South Florida, is going for $1,500 a pound. Think about that. From all the way from 28 to 32,000 to 1,500. Availability is off the charts. Purity is off the charts. 5 years ago, we would be doing a meth investigation. And if it was a good case, it would probably entail anywhere between 3 and 5 pounds at a pop in a shipment. Lately now, it is common to see cases here in Florida where we are trying to do a regular local level meth investigation, and you got a guy that is actually bringing in anywhere between 20 and 80 pounds a pop. To put it into perspective, now that we're discussing both things, fentanyl and meth, during the last 4 years, and this is just DEA Miami Field Division, state of Florida only, our fentanyl seizures have increased 527%, and our seizures of meth have increased a little bit over 1,500%, okay? It just boggles the mind. We're getting overrun. But let's talk about what is happening now that is different. And you look at this slide, and you look at the picture to the left, and you see the traditional idea that we have in our minds of how a drug deal goes down. You know, you meet somebody somewhere in a park, in a corner of a street somewhere, and you hand over some cash and you get some dope, okay? Well, in the 21st century, 2023, we live in a different world. If you have one of these, a smartphone, now not only you have the ability to communicate, you have an ability to radically change what is drug dealing. Because now, guess what? Through social apps, you can actually market your product. Instagram, Snapchat, you name it, Facebook. But you can also connect with people. You can also breach language barriers. Thanks to social media and thanks to emojis, you can actually now, doesn't matter whether you speak English, you speak Spanish, you speak French, Portuguese, Creole, emojis are universal. So you don't even have to speak the same language as somebody that connects with you on social media and that wants to buy your dope. Not only you can market and sell the dope, they can pay you with an app. They can pay you with Zelle, Venmo, you name it. Bitcoin, when they are doing transactions, buying directly from somebody that is not even in the state of Florida. Not only you can get paid for the dope, you can also deliver the dope. And we already spoke about parcels coming to your doorstep via the US Postal Service, via UPS, FedEx, but even Uber. Maybe today, before you jump on this meeting, you call through an app and you order some lunch, and Uber delivers. They came over to your office and brought in a sandwich, a wrap, or something. Well, guess what? You have people now that they're selling dope, and you have people that bought the dope, and they're being delivered to their house by a Uber driver that doesn't know. He's just bringing a shipment. It's a parcel. Okay, and it is actually dope. So folks, we have a problem because the ability to investigate this type of activity and to be effective and to be in a position to interdict and apprehend the people that are conducting these transactions is challenging. But more troublesome, real quick, this whole emoji thing and this whole thing about social media, this is a wake-up call for anyone that has children. And now our kids, they are engaging in social media at an earlier age. This could be happening right under your noses. And if you're not paying attention to what your kids are doing in social media, they may be exposed to this. I'll mention the Adderall, the fake pills of Adderall that is actually methamphetamine. We first detected them here in our AUR in 2019. We actually wrote a report about it. It has come to our attention that now, initially we knew that they were being sold in college campuses here in Florida, but now we got information that is actually happening in high schools. A lot of our kids, they have attention deficit disorder. They're being prescribed Adderall or similar medications. There is nothing wrong if they're taking Adderall that was prescribed by a doctor and that a pharmacy actually dispense that prescription. But if your kids are buying Adderall on campus, in school, they're playing Russian roulette because there is a chance that at the least worst scenario, it's just meth, and meth is highly addictive, by the way. That's bad news for your kid. But there is a chance too that it has probably been exposed to cross-contamination. There are people that are dying thinking that they are taking an oxy pill that turns out to be a fake one. It has fentanyl. The same thing with Xanax. It's a commonly fake pill that is also being manufactured, as well as Percocet. The same thing is happening with Adderall, with meth. So people are actually playing Russian roulette. And folks, it's not only meth and fentanyl, it's everything. It's polydrug drug trafficking. Everything under the sun is being actually offered via social media. I urge you, for those of you that are listening, to visit dea.gov. There is a link there under the title of prevention. If you click there, there's going to be a myriad of resources. Among them, there is a emoji decoding guide that shows you how in social media these people are communicating to sell dope. I highly encourage for you to visit that page and pull that data. We have a mandate at DEA. This past year, we switched gears and we are actually focusing on 4 things and 4 things only. We're focusing on the Sinaloa cartel. We're focusing on the cartel Jalisco Nueva Generación. They are 2 cartels that are primarily behind the mass production of fentanyl and meth and the mass distribution of those 2 drugs in the nation, within our borders. So we're investigating them. So we are emphasizing on fentanyl. We're also emphasizing on methamphetamine. And we're also emphasizing on China, because they are the source of the precursor chemicals that are being shipped to Mexico and that is leading to the ongoing crisis that we have today. And folks, we're basically done. This is real quick why they're doing it. When the precursor chemicals get sent to Mexico, and in Mexico, they can mass produce, synthesize the fentanyl, they illicitly manufacture fentanyl. A kilo of that synthesized fentanyl, in Mexico, out of a kilo, a single kilo, you can actually produce 500,000 pills. The ones that are being sold right here in the streets, the ones that are actually killing our people, okay? And it's for profit. They don't care how many people, they just want to hook them. And like I said, once they have a batch that mass kills a bunch of people, they begin to tweak their recipe so they can still produce and hook people up. And think about it, the incentive that they have. In the past, when they bought heroin from Colombians, or where they were doing their heroin in country, in Mexico, they depended on cultivation, on opium poppy. By procuring the chemicals from China, they bypassed the whole issue about dealing with cultivation. The same thing was as to why they're doing methamphetamine in max quantities now. The same rationale. Instead of buying cocaine from Colombians and shipping it to Mexico and paying them a fee, it is in their best interest to just mass produce methamphetamine in their country by simply importing precursor chemicals from China and then selling it. There is a demand for that here, unfortunately. In the past, we used to see strictly Mexican nationals involved in methamphetamine trafficking. Here in Florida, we're seeing everything. We're seeing Cubans, Dominicans, Puerto Ricans, white people, African Americans, you name it. Everybody's now dealing with methamphetamine. And folks, if you ever have the opportunity to visit our headquarters, we have an exhibit. We are doing this outreach that I'm conducting right now with you because we want to at least pass on the word and educate you on what we are seeing unfold in real time, to empower you, empower your families, your friends with knowledge, so you can do the messaging, that you can help us do the messaging and share this information with your loved ones and look out for them, okay? That's about it. In the slide there, you have my email address. Feel welcome to reach out. We are in a posture of offering to do this to as many people as we can. I'm not the only one involved in this. We have a full team here at the DEA Miami Field Division that is conducting these outreach chats, and we will obviously update it as new information becomes available. And I want to thank you for the invitation to speak before you today. And if anybody has any questions, I'll be glad to address them.
Thank you, Ernesto. That was quite a handful. Question: we see the emergence of xylexine, the
Yes.
called tranq. In 2022, the stats from our medical examiner here in Palm Beach County show approximately 7%, a little more than 7% of the total accidental overdose deaths opioid and other, because it's not opioid, but the total number 555, it's 41. So that's a little over 7%. Do you see that as an emerging concern for DEA?
It is actually, it pains me to share this insight with you guys. I am Puerto Rican, okay? This problem of xylazine, you can blame it on Puerto Ricans. Puerto Ricans pioneer the use of xylazine as an adulterant in heroin in Puerto Rico in the early part of the 21st century, okay? If you go to YouTube and you search for Zombie Island, it's one of these Nat Geo documentaries, and it shows you in a 1-hour documentary what was the Puerto Rican experience around 2006 or so. And it's very compelling. But the short story is that has been exported, the technique of using xylazine as an adulterant. It is running havoc in Philly right now. In Philly, there is a huge Puerto Rican and Dominican community. They are pioneering that in the East Coast. And now we're seeing here in Florida. I'm paying attention to the National Forensic Laboratory System. The DEA runs it, but it's a collaboration between county, state, and other federal laboratories across the nation, including also Florida. And I took a look last week at the request of other folks. And yes, during the last 3 years, we have seen a systematic, it hasn't been like a full blowout, but it is actually popping up in multiple samples across the state of Florida. So I agree with you. This is probably in the short term, one of the concerns that we're gonna have. Central Florida used to be our heroin capital in the state. That 20-year window that I show you of the past, Orlando, Florida, Central Florida was a heroin capital for the state. We have a huge Puerto Rican community and a huge Dominican community in Central Florida. It is no surprise to me that they have actually imported the technique and that they have begun to do the same thing that they did in Puerto Rico 15, 20 years ago.
Wow. Any questions of Mr. Gray? Anybody? Well, those were startling numbers. And I do have one last question regarding the 500,000 pills from a kilo.
Yes,
At
sir.
2 milligrams, is that a potential lethal dose? Or is
Yes.
that just a dose that would be below lethal?
No, that's the dose that has been proven that is at the deadly level. Yes.
Okay. All right. Wow.
Yeah. And like I said, out of the bulk, out of every 10 pills, right now, at least 6 of them do contain that level of dose.
My God.
Wow. Now, when you say 6 out of 10 pills, is that 2021 numbers? 22? What's that?
2022.
2022. Wow.
Yep. Mm-hmm.
Amazing.
Yes, I saw another hand up. I'm sorry. I thought Lori, were you?
Oh, yes, I just asked to have him put the first slide on his screen if he could.
Okay, sure, I can.
Thank you. I just wanted to get the title of it. Thank you so much.
Yeah,
All
and
right.
this will be up on our website next week, early next week. So if anybody has anybody else that you feel would benefit by hearing the presentation, please just go to the state attorney website, click on State Attorney Addiction Recovery Task Force, and our meeting, and all the materials and all the presentations will be on. Okay, thank you again, Ernesto. That was
Thank you.
compelling would be an understatement. Susan, did you want to ask a question as well?
No, I was just admiring and saying wow on the presentation. I thought I was muted.
Okay.
My apologies. Thank you very much, though.
My pleasure.
Okay,
Thank
everybody.
you.
So anybody have any closing remarks before we end the meeting 5 minutes early? Hearing none, thank you all so much for being part of this. Please, if you can, at all, get the message through to the legislature to support the SB 210 and HB 295. Also, the fentanyl test strip bills, I think it's 164 and 165. And with that, I guess we'll see you in 2 months. And let's save some lives.